Welcome to our first of the 2021 Stroke Educational Series. My name is Deb Moats, and I'll be your moderator today. And feel free to ask questions throughout the presentation by typing them in the chat box on the right hand of your screen, or pressing the microphone at the bottom of your screen, or if you're using the phone audio, press *6 to come off mute. Everybody will be placed on mute to begin with. I have the distinct pleasure to be able to introduce Dr. Robert L. Lunde. He is a professor in the Department of Neurosurgery and Emergency Medicine and medical director of the Neuro ICU at the University of New Mexico in Albuquerque. Dr. Lunde is the director of the University of New Mexico's Neurosciences Intensive Care Unit, providing modern neurocritical care. His enthusiasm and thorough patient care, along with his combined training in emergency medicine and neurocritical care, ensure that his patients receive the best possible care as quickly as possible. His friendly, professional bedside manner makes him a favorite to his patients and the families. In order to provide continuity and shared resources, Dr. Lunde has dual faculty status and shares his time in the Department of Neurosurgery and the Department of Emergency Medicine. He also will be working with the department to provide emergency stroke care for patients in rural hospitals through their telemedicine technology. Dr. Lunde is a volunteer supporting the American Heart Association, American Stroke Association in many capacities, and he currently serves on the Southwest Affiliate Stroke Committee. His presentation today is titled Acute Ischemic Stroke Guidelines. So welcome, Dr. Lunde.
Well, thank you so much, Deb. Appreciate that introduction. And I just wanted to thank everybody for being a part of this. This is super interesting stuff, a lot of controversial stuff, so much so that in 2019 they had to update the 2018 guidelines. Soon enough, I'm sure they'll come out with a newer set of guidelines, but for now, this is what we got, and it's still pretty good information. So let's get right to it. I have no financial disclosures, and this is essentially the document that we're going to be building the talk on top of. American Heart Association, American Stroke Association guidelines. There's a lot of huge names in here. Just a shout out to some of the great EM docs that I've worked with in the past. Dr. Opoyadewe is an EM neurocritical care doc out of Cincinnati. Actually just became chair of the Department of Emergency Medicine at WashU, which is where I trained. I also went to med school in Cincinnati, so that's where I know him. Ed Yauk was my med school advisor in med school in Cincinnati, and I think, not on this document, but there's another one that we'll talk about where Pete Penagos, who co-chaired the committee for Mission Lifeline Stroke, he was also one of my mentors. So I've been lucky enough to work with some of the big minds on acute stroke care in the United States. So real quick, I think it's super important that we understand what we're talking about whenever we talk about recommendations. So there's two ways that we discuss it. And one is the strength of the recommendation, like how strongly the association, in this case, American Heart Association, feels that you should do or should not do certain tasks. And then there's also the amount of evidence that goes behind each of those recommendations. So just to quickly clarify here, the class 1 recommendation is a strong recommendation. You got to do this. If you don't do this, you are potentially putting yourself at risk for malpractice if you're not doing these kinds of things. It's that strongly recommended. Class 2A is a moderate recommendation. It's reasonable to do so. These, in effect, you should be definitely doing these things. 2B, also you probably should be doing these things too, but definitely not as strong a recommendation as class 1. Class 3, don't worry about it. Don't do these recommendations. The AHA does not suggest doing these that are ranked as a class 3, and class 3 harm This is definitely don't do these potential interventions. We'll be talking about 1, class 3, no benefit in this talk. The level of evidence, the quality of the evidence. This is, the trials that went into figuring out what we need to be doing and providing us that backbone for how strong of a recommendation we want to give. So a level A is the highest level of evidence that has more than one randomized controlled trial, meta-analyses, everything points to the same direction in regards to the recommendation. Level 2B, this usually comes from a good randomized controlled trial, at least one of those, and meta-analyses that are pointing in that same direction. Level 2B, non-randomized, so that's no RCTs, no randomized controlled trials, but still evidence is still pointing in the same direction. Sorry, let me just turn this off. Okay. Level C is, of course, worse. There's no randomized controlled trials. There's some decent data on there, and level C essentially comes down to this is what makes sense. This is what the experts do, but we don't have any good data to back that up. All right, so we'll go ahead and start then with a pretty controversial topic of pre-hospital bypass. So this is starting with EMS recognition of a patient with a stroke and figuring out which hospital they need to go to. So just to read word for word at the top here, if eligible for IV alteplase, the benefit of bypassing the closest IV alteplase capable hospital to go to a thrombectomy capable center is uncertain. It's a class 2B recommendation. So again, we're in favor of bypassing the closest IV alteplase in order to go to the thrombectomy capable center, but it is it's definitely not the strongest recommendation. This is backed by level B evidence, so that's pretty good. At least one RCT and the meta-analyses are pointing in the same direction. So the AHA also publishes this Mission Lifeline Stroke, which is a super helpful document. In this case, this document helps provide a systems of care backbone for how EMS can get the patient to the right place. And it looks like this. It seems a little complicated, but essentially on the bottom left there, if they suspect a stroke, you start the things. You figure out your last known well, and then you try to figure out if you suspect a large vessel occlusion. Right here. So this is where that the first part of the controversy. And this controversy is how well can we detect a large vessel occlusion in the field? Because if you get it wrong every time, then you're just wasting patients' time. You're wasting that eligibility time. You're wasting brain cells before getting alteplase. But if you get it right, you get them to the more definitive answer of the thrombectomy faster. So again, the problem with the stroke severity scales, not the initial stroke scales, not like your normal Cincinnati or your normal LA pre-hospital stroke scale, but these are the stroke severity scales. These stroke severity scales all had area under the curves of 0.7 to 0.85, which is not too bad. The probability of having an ELVO with a positive ELVO prediction test was thought to be only 50 to 60%, whereas potentially greater than 10% with a negative test could also have an ELVO. Thus, more effective tools are needed to identify suspected stroke patients with strong probability of ELVO. So that's the counter to this recommendation, is that our tests just aren't good enough yet. And if they're not good enough, we potentially over triage, we potentially delay alteplase. And if it doesn't catch, and if it doesn't catch, what are we doing? My counter to that, or if I was a patient with a large vessel occlusion, I would want you to take me to the more definitive care for that sooner, because the data is pretty strong in saying that thrombectomies get you to a better outcome, more so than alteplase. So if you could catch 50 to 60%, I think that's theoretically a win. That's good enough for me, but there's definitely room for improvement. Now going back to the algorithm again, if you suspect the elbow and you're going down that third column downwards, and the last known well is within 24 hours, this says to bypass the to go to the endovascular capable center as long as you can, one, not miss out on getting alteplase. If bypassing is going to cause you to miss out on alteplase, don't bypass. Just get your TPA at one hospital and then go to the endovascular capable center. And your comprehensive center is less than 30 minutes away. That's what these recommendations are saying. American Heart also does state in a parallel document to this that there is insufficient evidence on specific thresholds of these time limits and additional time travel for which to bypass other hospitals. So it can be very location specific, can be kind of patient specific, but these are just open guidelines to provide EMS groups within a city. Here in Albuquerque, we have our Albuquerque Fire, and we have Albuquerque ambulance systems those are our two big ambulance systems in town, and those guys work together to make a lot of joint protocols for pre-hospital providers. So it's working through them with these guidelines that we come up with our recommendations. So again, thresholds of additional time travel, insufficient evidence. You're trying to weigh delays in alteplase to delays in thrombectomy. Moving on now to, sort of moving on. Pre-hospital bypass to healthcare facilities able to perform thrombectomies if a patient is ineligible for thrombolysis. So this is now, they don't even qualify for thrombolysis because they're out of the time window, or they're on Coumadin and they take it every day religiously. So they're not going to be thrombectomy candidates. Well, let's just go to the place that's going to provide the only possibility for acute stroke treatments. So go to the place that can do endovascular therapy or mechanical thrombectomy. So class 2B recommendation, level of evidence C. But like I said, if they can't get alteplase, there's no reason for them to go to an alteplase only center when they have the potential to have a thrombectomy. All right, now this is getting to some cool, interesting, newer stuff. Some patients can get alteplase after 4.5 hours from the last known well. So as many of you already know, the NINDS trial back in the 90s was positive, was the first trial that showed benefit for using alteplase and treating acute ischemic stroke within the first 3 hours. ECAS-3 was the third ECAS, and that demonstrated benefit of giving alteplase within 4.5 hours with a certain newer set of exclusion criteria. And now we're talking about extending this beyond 4.5 hours. So this is a class 2A recommendation. So definitely has benefits and comes with level B evidence. So the first trial that they mention here is this one in 2018, MR guided thrombolysis for stroke with unknown time of onset. This one came out in 2018 out of the New England Journal, called the Wake Up Trial, big trial. This one had 503 patients. They randomized patients to get alteplase versus standard of care. Happened in 8 European countries at 70 different hospitals. And they included adults, not too old, last known well, outside of the 4.5-hour window. Stroke recognition of symptoms within 4.5 hours of presentation. But most of these were patients that were that woke up with their symptoms. So they went to bed fine, they woke up with symptoms, and then they showed up to the ED. They did early stroke. They found the early strokes based on an MRI. So this DWI positive, that's diffusion weighted imaging. That's one of the sequences that we get with the MRI. That if that was positive, which shows up very early when someone's having a stroke, like within a few minutes, and then flare negative, that's another sequence on the MRI. That shows a positive, we think, in somewhere between 4.5 to 6 hours of the stroke. Some might argue that it shows a positive when when there's more edema associated with the stroke, so the stroke is worse. So this helps us to be able to determine how old the stroke is and whether or not we think that there's going to be salvageable brain. They excluded patients that had ICH for obvious reasons. They excluded patients that had a planned thrombectomy. And I think that's really kind of important here because when this trial was done, not everybody was getting thrombectomy. So that's kind of huge. NIH stroke scales that were really big, greater than 25, and lesions on their CT scan that had greater than 1/3 of the territory of the MCA as out, they didn't include those patients. And obviously, if you couldn't get alteplase, you weren't.
Dr. Lunde, I think you went on mute.
I'm going to assume that was just the second. All right.
Just a little
Okay,
bit.
great. Okay, so this is the demographics graph or chart from the study. And I think it's really important to note here that the median interval between the last known well to the symptom recognition and, last known to be well and symptom recognition in hours was 7.2 hours in the alteplase group, almost exactly the same as the placebo group. Yes.
Your screen is not being shared anymore. So if you can re-share your screen.
Absolutely. I think I'm sharing the wrong screen.
Yeah, it's
now the right screen?
Yes, perfect.
I apologize, guys. I'm so sorry for that. But again, here, all right, we see that the times from last being well to symptom recognition was the same. And this is the other thing that I already briefly mentioned. I think it's important to know that up to 15% of these patients had large vessel occlusions and potentially more. So it throws a little bit of question into, does this apply to all the patients that don't have large vessel occlusions? we could see here that the alteplase group had 131 patients, 53.3% had a favorable outcome versus the placebo group of 41.8. And on your shift analysis here, you see that there is definitely a trend towards better outcomes, a statistically significant trend towards better outcomes in the alteplase group versus the placebo group. And then in 2019, this trial came out. This is the Extend trial. This trial was done in Australia, New Zealand, Thailand, and Finland. And they did another double-blind placebo-controlled trial with alteplase. And they stopped this trial early because of wake up. Everyone's trying to save money. So when a very similar trial comes up pretty positive, a lot of other trials will stop and do an interim analysis and see if they need to keep spending money. So the inclusion here on this specific trial was outside of 4.5 hours, but within 9 hours. They had to have hypoperfused but salvageable regions of brain detected on imaging. And the specifics of that were a lesion core to mismatch of 1.2. So it had to be, the perfusion deficit had to be bigger than the core. Absolute difference in the volume of dead brain versus ischemic brain had to be, the difference there had to be at least 10 mLs, and the ischemic core volume had to be less than 7 mLs. 7 mLs volume of brain. They used MR and MR perfusion or CT perfusion. And for those of you guys that don't look at these all the time, this right here is an example of a CT perfusion. So on the left side of the screen, you see that fuchsia color there. What is being outlined in fuchsia is what the computer has determined to have a CBF, or cerebral blood flow, of less than 30%, 30% of what it should be. And that is what we consider essentially the core infarct. And they're measuring this one to be 17 mLs. And on the right-hand side of the screen, you can see what they're calling low flow time. Yeah, the parts of the brain that are getting low flow and are at risk of becoming fuchsia if nothing happens. So this is the Tmax, taking longer than 6 seconds, the time to, I think, maximum contrast. And that volume is 156. So there's a big difference on this particular patient with a mismatch ratio of 9.2 with a large amount of volume. So this is an example of somebody that has a small infarct and will probably have deficits from that, but has a lot of salvageable brain. And their exam could be somewhere in the middle, but could be as bad as the entire green. So if you can take out the stroke, if you could take out the clot via alteplase on this patient, then awesome. Then you are potentially providing them with a lot of benefit. Here's an example of an MRI with an MRP. So again, the fuchsia is considered the infarct core, and the green is considered the low flow or the at-risk part of the brain. Or I should say the difference between the two is the penumbra. So this, for the MRP, shows a volume of dead brain of 89 mLs versus a volume of low flow brain at 124, leaving us with a mismatch ratio of 1.4 and a volume of 35. So definitely not as much brain to save. And the amount of dead brain that the patient already has here is too high for us based on these trials to try to save. The Extend trial exclusion criteria had modified Rankins of greater than 2 already, severe strokes, and patients being planned to go to thrombectomy. As you can see here, there is improvements in the neurologic outcomes for the patients that got alteplase, and a proof in concept here Under tertiary outcomes, you can see the increased amount of recanalization, 67.3% in the alteplase versus 39.4, which was essentially the spontaneous recanalization of the blood vessels heading towards the stroke area. So we were more likely to open up clots and more likely to provide functional outcomes by giving patients alteplase in this extended time frame based on imaging. And again, here's another shift analysis. These are super common in stroke trials. And you can see this statistical trend towards improved outcomes with a lower modified Rankin score. I love how this this document, the new guidelines, have all these controversial topics in them, and this is definitely one of them. So they're actually not recommending alteplase for a certain group of patients. So for mild, non-disabling strokes, NIH stroke scales of 0 to 5, alteplase is not recommended. So this is the sole no benefit one that we were talking about discussing today. So this was based on this RCT, this PRISMS RCT, came out in January 2018. And they had 75 hospitals. They designed the trial for 948 patients in the United States of alteplase versus aspirin within the first 3 hours. They only enrolled 313 patients at 53 centers. So things were not going very well for them to be able to pick up more places and more patients, and they ended up having to stop. The sponsor, this was an industry-sponsored trial by Genentech. They said, quote, financial decision based on the fact that the trial could not be completed within the allotted funds in the specified time frame. So that's kind of sad that they didn't get to finish this trial, and their eventual conclusion here was it's very early study termination precludes any definitive conclusions. But thankfully, they were honest and put out the data on the patients that they did have. And we'll talk about that data in a little bit. But before I do, I think it's important to mention their inclusion of non-disabling strokes. So what is a disabling stroke? And they define that as the inability to perform the activities of daily living or being able to go to work. So if you were able to do these things before and you couldn't do them now, that's considered a disabling stroke. And that determination was made by the local clinicians that were talking to the patients and in consultation with the patients and their family members. There's also an ability to walk. That was considered a disabling stroke. So, sometimes you see a patient with a small stroke that can't move their hand, and it's not that big a deal. But if you're 80 years old, you're right-handed, and your left hand can't move as coordinated anymore, it's not that big a deal. It might not be disabling. You could still eat, you could still talk, you could still interact. You wouldn't really necessarily call that disabling, but if you were a concert pianist and now you can't return to work, that's disabling. So it's a little bit different for every patient, and it's definitely something that is difficult to put into practice globally, but really needs to be down to the people that are involved in that physician-patient relationship and trying to make that determination. The exclusion criteria for the PRISMS trial was if they were already disabled, if they couldn't take aspirin, dysphagia, or any contraindications to alteplase. And you could see here's their shift analysis. And although you could see placebo on these two, so the alteplase is on the top and the placebo is on the bottom. It looks like there's a trend towards better outcomes on the placebo and a trend towards worse outcomes on the alteplase group. Right there. So this is the trial that made the AHA say, there's no benefit, we don't have to give it to the patients that have these small and non-disabling strokes. Here's a new one, tenecteplase. Tenecteplase may be a reasonable alternative to alteplase. But specifically though, in patients eligible for mechanical thrombectomy. I think this is a really cool potential move forward for us in general, because alteplase, yes, it has been the only medication, only lytic used that had statistical benefit in treating all comers with stroke within a certain time frame. But it does come with, it's not just weight-based, these are all weight-based, but it comes with a small bolus followed by a 1-hour infusion and a lot more potential med errors that are associated with those. Tenecteplase, however, is a simpler medication in that it's just a single one-time bolus. So this makes transport a lot easier. Depending on the EMS agencies, certain paramedics might be able to transfer patients with ongoing drips and some might not. So if that's the case, then this really opens up the potential for, what rigs are able to transport patients from one center to another. So that's a huge potential benefit there, because it would decrease that time of searching for the right paramedics and searching for the right rig in order to transfer that patient. The trial that demonstrated this was the Extend IA TNK trial. They had 202 patients in Australia and New Zealand, open label, blinded outcomes. It was a randomized control trial. And they used tenecteplase versus IV alteplase in patients that were about to go thrombectomy. Super important in patients that were about to undergo thrombectomy. The Extend IA TNK inclusion criteria, you had to be a potential candidate for both mechanical thrombectomy and IV thrombolysis, so they're within 4.5 hours. The large vessel occlusion locations were something that we could get, ICA, MCA, or the basilar artery. And it's important to know that there was no upper limit of the NIH stroke scale and there was no upper limit of age. And here you can see the primary effect, the primary outcome here, substantial reperfusion at initial angiographic assessment. And the number of patients with a that had their vessels opened up by the time we looked at them under fluoroscopy was actually higher in the tenecteplase group than it was in the alteplase group. So that's important to see. And then here you can see on the secondary outcomes that also came with median score on their NIH was statistically decreased also. Their functional independent outcomes, almost statistically different. In patients with minor non-cardioembolic ischemic strokes, so not the AFib patients that throw up a clot from their heart. On these patients that had a low NIH stroke scale, less than or equal to 3, and did not receive alteplase, just because they, for whatever reason, we found that we should be starting clopidogrel and aspirin within 24 hours of the symptom onset and continue for 21 days. And this is going to reduce this recurrent ischemic strokes for up to 90 days. This is a change. This is a big change. As you can see here, it's a class 1 strong, lots of benefit. You got to do this with level A recommendation. And I think it's important to know that this is, like I said, a change, because the older trials were saying that this wasn't of benefit. And I think a lot of that came from putting this on too sick of patients and putting it on for too long. Because a lot of the patients in those older trials had bleeding problems, either from bleeding into their stroke beds or having GI bleeds. So what they were able to do in the more recent trials is find the less sick patients, the smaller strokes, and only do the dual antiplatelets for when they're at the highest risk of getting their next stroke, which is early on. So the CHANCE trial, this was the big trial that helped determine this one. 5,000 patients in China with a mild stroke or TIA. Both groups got open labeled aspirin for 21 days, and that dose was whatever they wanted. And the treatment group received a 300 milligram load of Plavix or clopidogrel, and followed by 75 milligrams per day for 90 days. And they started this treatment within 24 hours. And you could see that there's a significant reduction in the patients having strokes and MIs, all-cause mortality, significant reduction in those on the dual antiplatelet group. And the bleeding was not statistically significant between these two groups. So by reducing the duration, you're able to decrease the amount of bleeding, but by having it on, you're able to reduce the amount of strokes that are coming up. The POINT trial, the other new one, 2018, that pointed in the same direction, another randomized controlled trial. This 4,800 patients, North America, Europe, Australia, and New Zealand, enrolled patients within 12 hours of their mild stroke or TIA. Randomized control trial, again, 600 of Plavix followed by 75 per day. Everybody received aspirin, and they excluded patients getting that were going to get anticoagulation. And so this trial was also positive. Their composite outcome of strokes and MIs and death from ischemic vascular causes, that was reduced. The aspirin group had 6.5% versus 5%. Ischemic strokes were reduced 4.6% versus 6.3%. These are smaller differences, but in the grand scale of things, you're reducing disability on patients, and it's meds that are that you take at home, that you can give relatively easily. So. Oh, and we talked about this already. Why were these dual antiplatelet trials successful when the others weren't? Again, this was in the particularly high risk of recurrent stroke, so early on after their first stroke. So they enrolled the patients within the first 24 hours, and their low risk of hemorrhages. So again, less severe stroke and TIAs are less likely to bleed. Now moving on to mechanical thrombectomy. So patients within the 6 to 16 hour time frame of the last known well. I should start out by saying the 0 to 6 hour, that's old news. That's not a brand new recommendation. Of course, we should be doing mechanical thrombectomy in patients with large vessel occlusions within the first 6 hours. But this is the new stuff in these guidelines. New in 2018, but not in the update in 2019. So if you're within the first 16 hours of last known well and you have a large vessel occlusion, you can still get thrombectomy if you meet certain criteria. And that criteria, we'll talk about that criteria here in a second, but I want to point out This is a class 1 recommendation, so super strong recommendation with level A evidence. So you cannot get a stronger recommendation or higher quality of evidence than what this recommendation has. So there's 2 trials. The first one we'll talk about is the DAWN trial. This one came out first. Thrombectomy within the 6 to 24-hour time frame with a mismatch between the patient's deficit on their exam and the infarct size. They planned for 500. They enrolled 206 in this multi-center prospective RCT randomized controlled trial. Bayesian adaptive enrichment design and blinded assessment of endpoints. That Bayesian adaptive enrichment design is kind of tough to wrap your head around, but essentially the plan going into the trial was they were going to assess it at certain time points, at certain numbers of patients. And if they had either a super positive or super negative result at those earlier time points, then they would stop early and publish after that. This was an industry-sponsored trial, which is different than the next one. But it is important to note that the authors had unrestricted access to the data, but the analysis was performed by data management staff from Stryker with oversight from independent statisticians. Inclusion criteria included pre-stroke modified Rankins of less than 2, so you had to be pretty independent and be able to work. You had to have a large vessel occlusion present in the internal carotid artery or the first segment of the MCA. And the next part's the important part here. It's this mismatch, this clinical symptoms versus the imaging core infarct. So if you look here, they stratified it by age, but essentially you had to have a decent sized stroke based on exam, an NIH stroke scale of 10, and an infarct volume of less than 21 mLs. If you were on the younger side, less than 80, you got to have an infarct size less than 31 mLs. And if you had a really big stroke with an NIH stroke scale of greater than 20, your infarct size could be less than 51 mLs. So the imaging that you need in order to follow the DAWN trial includes either an MRI with the diffusion weighted sequences or a CT perfusion. We looked at a couple examples of that before. So getting now to the endpoints of this trial is that the functional independence at 90 days, as you can see here in the thrombectomy group, was 49%, had functional independence versus only 13%. That's a huge, huge number. Just so you know, the functional independence is defined in this trial by a modified Rankin of 0, 1, or 2. So definitely able to still walk and get around and do your own ADLs. But a big difference in their outcomes. The intention to treat analysis here, the shift analysis of this was, as you can see, definitely trended towards better outcomes in the thrombectomy group. And pretty much in all the subgroups. And then the next trial, this is the DEFUSE 3 trial. This was in the 6 to 16-hour time frame. So that's why the class 1 evidence recommendation goes up to 16 hours, because there's 2 RCTs that go to this time frame. This was done on 182 patients in 38 centers in the United States. They did endovascular therapy plus medical therapy versus medical therapy alone. This one was not industry sponsored. This was sponsored by the NIH. And you could use any FDA approved thrombectomy device. The non-contrast CT done with this has aspect score greater than 6, That's an objective way to determine how much good brain versus dead brain on that MCA territory. So this is, you have to have a pretty good amount of good brain left in order to be enrolled in this. You have to have a large vessel occlusion present in the M1, I say, or elbow again, I'm pretty sure I meant to say ICA. You have to have a pre-stroke modified Rankin of 0 to 2. Again, that's, you had to be able to do your own ADLs. Your infarct core had to be less than 70 mLs, and you had to have a ratio of ischemia to infarction of 1.8. You got to use MR and MR perfusion versus CT perfusion. And here's, I think I showed you this one earlier, an example of an MR and MRP. So this trial is slightly different than the last one, where they used a, they were able to determine the core by imaging, but the penumbra essentially was based on the exam. This trial looked at both the penumbra and the infarcted core by imaging. So this is an example of somebody that has 89 mLs of dead brain and 124 mLs of brain that's getting low flow, leaving us only 35 mLs of penumbra, the mismatch volume there in the center. 89 mLs of dead brain would exclude this patient from getting endovascular therapy. Here's a CT perfusion. So this is a core infarct. You can see in fuchsia on the left is super small, only 4 mLs, versus that on the green on the right, 81 mLs, leaving us 77 mLs of at-risk brain, and a ratio of 20.2. So huge chance for this patient to do really, really well. This one definitely would get a thrombectomy. So the results here, they only enrolled 182 patients because they stopped early when the Dawn trial came out and was so positive. Their shift analysis, as you can see here, definitely trended towards a better outcomes of the endovascular therapy. You can see here that we had the primary outcome and the secondary outcomes were positive. Functional independence was much greater in that endovascular therapy group. All right, and then for patients with, within the 16 to 24 hours of last known well, who have an elbow in the anterior circulation and meet the Dawn eligibility, mechanical thrombectomy is reasonable. So this is class 2A. Benefit is very much there with level evidence B, that single RCT for the Dawn trial up to 24 hours. So again, 16 hours, class 1, 24 hours, class 2A for the recommendations. We here at UNM are definitely doing thrombectomies up to 24 hours. So summary of the recommendations here. There's a lot of them. I apologize, but that's kind of the nature of doing a lecture on these kind of recommendations. So there's pre-hospital stroke severity scales are good. Use them. They're not as good as we want. Hopefully there will be better ones coming out in the future. Pre-hospital bypass in potential cases of large vessel occlusion can involve delays to alteplase, but you're weighing that against delays to thrombectomy. So local decisions need to be made. If the alteplase is out of the question, just go directly to where they can do thrombectomies, and that bypass is going to save you a lot of time. MRI imaging can find patients eligible for alteplase in that greater than 4.5 hour time frame. avoid alteplase in non-disabling mild strokes. Consider tenecteplase on your large vessel occlusion cases that are going to go for thrombectomy. Again, super awesome if you're not at the comprehensive stroke center, but at a primary stroke center and going to transfer them in. That's going to save you time, save your pharmacist time, and make it easier for you to be able to get the patient transferred. Dual antiplatelets for the patients that are having small strokes. Start that early and continue it for only 21 days. And advanced imaging can also be used to find potential thrombectomy candidates up to 24 hours after their last known well. So treat those guys almost as if they were coming in at hour 1. You want to find them early. All right, and this is my reminder that the slides are done. This is just a cool little picture from last summer. That's some elk down there in the bottom of this little valley in the Jemez Mountains here in New Mexico. And with that, I'm going to stop sharing my screen and open it up to questions.
Great presentation, Dr. Alunde. I don't see any questions in the chat box right now. Does anybody have any questions? You can *6 to unmute, or you can type them in the chat box. So it looks like there's no questions. So I just want to take the opportunity to thank you for, oh, wait a minute. Here's one. Are there any recommendations for a wake-up stroke protocol for TIA patients?
For TIA patients. So if they're TIA, they woke up with they went to bed fine, woke up with their symptoms, and the symptoms resolved, awesome, fantastic. I would treat those like you treated any of the other TIAs or the small strokes, i.e. dual antiplatelets for 21 days is going to be the best thing. You can't give those, once the symptoms resolved, they're not eligible for thrombectomy any longer or alteplase. So I would not do alteplase on those patients. I guess before that question was liability of not using dual antiplatelets. I can't say I'm the best person to answer that, but now that it's in the recommendation, I think it definitely puts you at a little bit more risk for not using the dual antiplatelets on these small strokes. Or at least if you're not going to use it, make sure you document why you're not using it, whether it be patient preference, something specific about this patient, they didn't tolerate Plavix in the past, making them higher risk. I would, with any of these recommendations, that are positive recommendations, you want to do them or at least say why you don't do them.
And I think that I combined the wrong 2 questions.
Yeah, I think you did it right. Oh, maybe you did, yeah.
So
Not
yeah, back to any
antiplatelets.
recommendations for the wake-up stroke protocol.
Okay. Any recommendations for the wake-up stroke protocol? So I want to say my recommendation would be to have all your stroke, we here at UNM, if EMS calls us and tells us they have a potential stroke that had a last known well within the last 24 hours, we are going to stroke alert that patient. And essentially, we're going to take them seriously. We're going to do a door to CT, directly, bypassing the ED bed first. We're going to have our neurology residents come down and meet us down there for that initial assessment. And we're going to try to figure out if the patient needs a thrombectomy in that delayed time fashion. So that's going to require more imaging. But essentially, we start out with, they're walking through and we're talking to them while walking, like, how are you doing? Start the NIH stroke scale. When were you last normal? And calling the family if necessary. And based on that information, based on the rolling in imaging that we're getting, the non-contrasted CT scan, the CTA, if we see the entire MCA dead, then we're done. But if we see that looking good, then we move on to the next step and ask ourselves, is there a large vessel occlusion? If there's a large vessel occlusion with a lot of potentially good looking brain there, then we ask ourselves, then we do either the CTP or the MRI and an MRP, depending on the availability of the MRI machine, which in our case, luckily, is about 20 feet away from our CT scanners. So that's not that big a deal for us. We're pretty lucky in that regard. But that's essentially our protocol. We treat it as if their last known well was within 24 hours. Same thing we do for everybody else that even come in the afternoon too. Criteria for 3.5 to 4 hours are not clear. Any suggestions? Yeah, there's the ECAS trial did have a few more exclusion criteria than the NINDS trial did. That's definitely for sure. However, the more exclusion criteria you start putting on your protocols, the harder it is to get through any of them, and the longer it's going to take for you to give alteplase to. If you look at the FDA contraindications for alteplase, the list is really small. American Heart Association also has a nice list of inclusion criteria, which is short, essentially having an acute ischemic stroke, and they outline it for the 3.5 hours too. And they have a big long list of potential relative contraindications. And those, like I said, are relative. So you got to take those with a grain of salt on whether or not, how bad, did they have, for instance, do they have an intracranial aneurysm that is not protected? Did they never have a clip or a coil in there before? If it's a large one, a relative contraindication. And it's only a relative contraindication, not because we ever found that anybody was more likely to bleed, but some studies excluded those patients because of fear of bleeding. So that's why it's totally legit to give it to them, but you are a little bit more worried. Major surgery within the past few weeks, that's another one. What is the definition of a major surgery? I just pushed TPA a couple months ago on someone in-house, an inpatient that had an orthopedic surgery on their hip. They had hardware removed. And I just assumed, oh, this sounds like a big surgery, I'm not going to give them alteplase. And I was covering at a smaller hospital, one of our sister hospitals, covering the ICU that night. And I was trying to get the patient ready for transfer. And then the orthopedic surgeon called me and said, I heard my patient's having a stroke. I said, yes, I'm transferring them down to UNM to get a thrombectomy. And they said, should we be giving them alteplase? Because I hear that's something we should do. I said, well, everything is a go for alteplase except for the fact that they just had surgery yesterday, and I don't want them to bleed out. And he said, oh, the bleeding wasn't that bad, and it's an orthopedic procedure. If it bleeds, I'll be able to go in there and stop the bleeding. So here it was. My judgment was it was a large surgery. The surgeon's judgment was it wasn't that big a deal to take care of the bleeding subsequent to that. So I called the accepting docs that were going to be taking them down at UNM, and I said, hey, this is what he's saying. Are you guys all also okay with me giving TPA? And they said, if the surgeon says they could stop the bleeding, the surgeon says they could stop the bleeding. Give the TPA. So we pushed TPA on a post-op day one, which was new for me. So relative contraindications, that's, I guess, my biggest, the biggest problem there with that 3 to 4.5, and even after that. So I think my suggestion is to try to limit what goes on the papers for your residents and for those around you to the big contraindications, and clearly step out, clearly say, if you're going to write all the contraindications, that which ones are relative and which ones are absolute. That will help out. And the 4.5 clear criteria for 3 to, okay. Aspirin 81 plus Plavix for 21 days, then aspirin or Plavix. Those studies said aspirin after the 21 days. They didn't keep going on the Plavix. So that's what I would do. And Marty Tebow said, thank you. I have a meeting, but appreciate this information. Thank you, Marty. I see anonymous attendee on the Q&A said, for patients greater than 4.5 hours from stroke, then we should give alteplase if in a center unable to do thrombectomy. Do we need to get MR first prior to stroke? So if you're in a place that can't do thrombectomy, I think the biggest thing you could do is actually transfer for thrombectomy. No one's done a head-to-head of alteplase versus thrombectomy in the post 4.5 hour time period. So I wouldn't do that. I wouldn't not send the patient for thrombectomy and give them alteplase instead. I would try to get them on a helicopter, or try to get them on an ambulance and get them going for thrombectomy. I think that's going to be the most legit thing you could do and less likely to get you sued. It is, as we did see a good chunk of those patients in those delayed alteplase trials, they did have thrombectomy. They did have large vessel occlusions. So hopefully one day we'll have a better answer for you, but I would definitely point in getting to definitive endovascular treatment first. And do we, to answer the second part of the question, do we need to get MRI first prior to stroke? I think you mean, do we need to get an MRI first prior to giving alteplase? And the trials, I'll just pull up the on DEFUSE. Okay, there we go. Share screen. For the Wake Up trial, this one used just the MRI. And then this one, the Extend trial, used the MR with MR perfusion and the CTP. So you can get this done. You can give alteplase beyond 4.5 hours if not going for thrombectomy based on a CT perfusion. Okay. So that is possible.
Our time is up. Yep, and we're a little over time. So just like to thank you so much for your time, Dr. Allende. It was an awesome presentation. Thank you to everyone who joined us. And if you have any questions, please don't hesitate to reach out and I can get the question. So thanks for your time. Have a great rest of your day.